Good morning. My name is Richard Vize. Welcome to this webinar brought to you by Together for Health, which is a series of events about health across the public sector led by Dodds Group and IT solutions specialists Citrix. And thanks for making the time in no doubt busy schedules to join us this morning. So we're here today to discuss connected IT to deliver care, any place, any time. As we've all seen, as a result of the pandemic, hospitals are being reinvented as centres of intensive care, with many other services moved into the community or to other settings or delivered virtually. And this is driving the largest shake-up of NHS care delivery in its history, and with it, the IT infrastructure that supports it. At the heart of this reconfiguration is the need for connected health and IT infrastructure that will enable clinicians to deliver patient care effectively wherever they are, from an intensive care unit to someone's home. And access to data and systems in any location, anytime, has never been more essential. So in this webinar, we'll be hearing from transformation leaders at the heart of delivering connected systems over the last 12 months in particular. And I'm delighted to welcome three expert speakers. Our keynote presentation will be from Dr. Adrian Hayter, who is speaking today in his personal capacity as a GP, although he also has a national role as Clinical Director for Older People and Integrated Person-Centred Care. And Adrian will be joined for our panel discussion by Justin Beardsmore, the Chief Technology Officer at Lewisham and Greenwich NHS Trust, and Jonathan Murden, the Lead Healthcare Technologist at Citrix. So Adrian, over to you for your keynote presentation, please.
Thank you very much, Richard, and it's great to be here today to speak to you all, and really kind of, I think, to think about the role of technology as an enabler for care. And as a clinician myself, as a GP who works at the Runnymede Medical Practice, which is between the Berkshire-Surrey borders, and I've worked there for 25 years. I've seen technology really play a part in terms of supporting people's care and being part of that enabler to be able to deliver better care. And also how care has shifted, and as Richard was saying, kind of care coming closer to people's homes and becoming much more connected. So really pleased today to be part of this this discussion, to give you some of my insights as a GP of 25 years, but also working within an integrated care system. And also thoughts around kind of some of the national drivers. So next slide, please. I thought I would just give you a little bit of an understanding about myself, and that's me there. I sat at my desk in the surgery. The surgery you can see behind me on my background. As I say, I've been working there for the last 25 years, and it's a population of 12,500, and we know the demographics of our population, and my population is a slightly older population than normal, and we've got a few people over the age of 95, and people are living longer throughout the time that I've been a GP. The age of people's their life expectancy has increased by 10 years or more. And now working as part of a PCN, a primary care network, and there are 1,300 of these primary care networks up and down the country, delivering care at a greater scale than in a practice perspective. And then part of an integrated care system, and then part of what our national delivery is. And this has been really useful in terms of how we have segmented care, and the national vaccination programme, as an example, is a way of kind of delivering care at a PCN level, which gives us the scale that we need to be able to deliver those 6.5 million vaccines, which we've reached so far, part of the process of the vaccination programme. Next slide, please. So I wanted to give two examples of why connecting care and having a record is really important. And I think the first example is around primary care. And I'd obviously say that, but being a primary care clinician, I have the privilege of working for most of my career with an electronic health record, and the richness of that data has been able to allow us in general practice to be able to use data and intelligence in a way that we can really understand our populations, and not only from a perspective of managing care on a daily basis, but also to have the intelligence around managing that care. And this is just the timeline from the 1970s all the way through to today, when, you know, an electronic health record is just taken for granted. When I first came to the practice, we had a GP IT system, which was used mainly for prescribing actually at the time. And we also had a separate word processor, which was kept in the secretary's office, which is a new bit of kit where we could do word processing and get really good letters. And I remember things were very disjointed and didn't communicate and work. We fast forward today, where we've got much more connected systems, and actually providers of IT are connecting with other providers to be able to join up some of those systems of care. So that's my first example, really kind of primary care record in England, being an example of how IT has really kind of delivered in a primary care setting. Next slide, please. And the next slide gives you, I think, kind of a worldwide kind of view and the role of digital health in terms of strengthening that universal coverage. So it's not only in our country, but really kind of across the world, how important the linkages are within a health system to be able to deliver care. So whether you're in the UK or whether you're actually in a developing country where resources are different, we can make best use of those resources by having some of those connections. And there is a real role in terms of digital health in actually kind of strengthening that universal health coverage. And this was in 2019, I think, a statement around the WHO in terms of how important the digital health agenda was, and actually thinking about the 10 areas that you can in a health system really start to think about improving care by some of the examples of linking care. So those are my two examples really of the importance of IT, digital health, and linking care. Next slide, please. And in this next slide, I really wanted to just mention the role of integrated care systems, because we're moving to that world where care isn't not just in segments in the hospital, in general practice, in the community, but actually what people want is care which is joined up. They don't want to have separated care. They want us to be, and in many respects, they're not concerned whether their care is delivered by a carer who may be part of a private provider commissioned by the local authority, or a GP who comes from the NHS, or a geriatrician, or a specialist in a hospital setting or a tertiary setting. What they want is good care, and they want that care to be joined up. And so an integrated care system is the way that the NHS is moving towards in its ambitions for a long-term plan for care to be personalised and be relevant to that individual, but if you like, also seamless in the way that it's delivered. So I wanted to quickly give you an example of how that connected IT at care at any time and in any place is an ambition that we all want to look forward to. And I'll give you the story of, and as a GP, I occasionally do some out of hours shifts. So this is where I'll be out in a car. I usually work on a Sunday evening, and a lot of the time on a Sunday evening, we are visiting older people who have probably waited quite a lot of time over the weekend to call for help and then call for help. And so I'll be out and about in a car going to visit people in their own homes. And this story was probably from about 7 or 8 years ago, when I went to visit an elderly lady who lived in her own home, who had some care going in. She had support in terms of a package of care going in 3 times a day. And it was one of the carers who called us in to see this lady because she was a new carer, and she was doing some personal care. And what she had noticed was that this lady had a condition which she was concerned about. And she'd found that this lady had quite a severe rectal prolapse when she went to look after her. And that's really where part of your rectum kind of comes out. And it can look quite a worrying sign for anyone who comes in. And actually, in some cases, it is a medical emergency. So I was called out to visit this lady, and this lady was living in her own home, had the care, but she had a degree of cognitive impairment, and she couldn't really tell her story. She couldn't tell me what had happened before. She couldn't tell me what her condition was like, and she couldn't tell me the treatments or the care that she had been given. So as a GP, we have to often investigate and gather evidence, and a quick look around the house to look for her medication, to look where she, what kind of drug treatment she was on, but also to see whether there were any nursing records. And it took me a while to find a little yellow folder tucked away in the kitchen. And in that folder was some district nursing notes, which were really helpful. And I started to look through pages of district nursing notes. And then there was an equal folder with the carers' records. And I was looking through those as well. And then I came across a piece of paper from the district nurse, which said that she had been in hospital previously, and they had and they'd recognised this condition that she had had, and she'd been in quite a few times, it seemed, on reading the records. And a bit further, looking through some of her health information, I found a discharge summary, and then from the hospital. And in that discharge summary, there was a clear plan, and there was a clear plan to say that this condition that she had was a common recurrence. She wasn't fit enough to have surgery to correct it, but in terms of the plan, which was personalised to her and had some discussion with family members, the plan was not to send her into hospital or keep sending her into hospital for an unnecessary hospital attendance, but it was actually to keep her at home. And actually, the rectal prolapse could be sorted out relatively simply, but over a period of time in a non-emergency or non-urgent way. So the reason why I'm telling that story is because the care was obviously not connected. It was not connected in time, it was not connected in place. But as a professional visiting that lady, that care was really important, from the nursing notes to the carer's notes to the hospital record to the general practice record, all of those things. And if we go forward a few years, with a connected system, we're going to be able to deliver personalised care in a much better way, at any time, in any place. And I think as clinicians, there are many of us who actually want to do that so that the care makes sense to individuals, and we use the resources that we've got in a wise way. Next slide, please. Finally, I think I wanted to, and this is a slide from my own system where we in about 2014, about 7 years ago, what we did was we started to get the local authority, and at that time I was a chair of a clinical commissioning group, and we worked with alongside others in other CCGs to bring systems of care and systems of NHS care together, to be able to create what we called a connected care programme. And in that, it had 2 elements. One was around a personal health record, and one was around a shared care record. And actually bringing those things together underpins the infrastructure that we've got for intelligence, the personal health record, and allows some connectivity. We're not there completely yet, but we're actually getting to a state where we can get that care delivered in most settings and at most times. Next slide, please. And finally, I think what I wanted to give you an example of was how we can have those local insights, how we can look at things in a different way, how we can gather intelligence. And in this this slide, there's kind of information around COVID and what's happening at the present time. And this has been really useful to our system to be able to develop early warning measures, to be able to think about care delivery in a person's place. Thank you.
Many thanks, Adrian. Particularly enjoyed actually the way you linked up the technology with the personal care and then rounding off with population health management, which is so much at the forefront of all our minds.
Yeah.
Now, if you're one of our guests today, you'll see there's a Q&A function on Glisser where you can pop questions or observations in to the speakers. So do please click on that function and put your questions into the speakers. So I'd now like to turn to Justin. So we've had the view coming from the community in the primary care setting. Justin, how has the technology needs of your trust and your clinical teams changed over the last year? And how have you responded to that?
Well, it's obviously events have made things change quite a lot. I think there's been a lot more focus on some of the areas we was already particularly working on. So in my STP in South East London, we had a very community focused approach. So we kind of already going that way, which allowed us to utilize cloud services and put down the foundations of good technology solutions. It's just kind of focused that mind and just moved it up a gear a bit more.
Right. And what have been the requirements? So from really when the pandemic started to grip last February, what sort of systems did you have to introduce or change?
Well, it's quite interesting because we obviously have an acute, we have 2 hospitals and we have community services. So what we found a lot is, you know, there was a lot of focus initially on the big ticket items like reconfiguring ICU, a lot of focus on those issues within the hospital. What we found as technologists, we didn't get much airtime. You know, there was a lot of people grappling with very large, big issues. And what we kind of needed to do was kind of anticipate what was next. And again, what was next was the self-isolating, the need to kind of start producing care offsite, whether that's a consultant who needed to move to a virtual consultation, but still need access to the EPR system to make those decisions. So we found ourselves as a team to kind of start to think, okay, we need to anticipate what the next questions come in and get ready for that, which we did very well to work with the suppliers. We found that kind of very easy because, like I said, we'd invested in the solutions that we could scale out. What we found the difficult issues was, you know, just buying anything, you know, buying a headset, the simple things that we ride on that supply chain that we all found very, very difficult. Yeah.
That's really interesting. So the technology team was having to anticipate the clinical team's needs.
Yeah, I mean, you know, there was certain, you know, when you go to Gold Command and things like that, there's only so much more focus. And, you know, everybody's struggling to be heard, and we kind of knew what was coming and we just prepared ourselves. Yeah.
And how has this changed the relationship between the clinicians and the technologists? Because I've got the impression from talking to colleagues in other trusts that the IT team has gone from the people who never are quite quick enough to give you a new laptop to actually being seen as strategic partners in clinical delivery. And really, the IT director and the medical director and the nursing director are working together to solve these critical problems.
I think so. It's a good point, and I think that the NHSI teams across the nation have all stood up. You know, I mean, whether that's just to help small things kind of understand the business needs. There's a lot of focus that you know we was there to deliver care. I think it's interesting where we've done some transformation in the community, and they was more mature digital. They kind of was more self-enabling. They kind of just got up. They trusted the technology, and they was able to move forward. Where in the acute space, where there was kind of less remote working, stuff like that, it was a bit more slow and just needed a bit more help. I think one of the biggest pluses, because of the approach we've taken with cloud services, with the stuff that people have done around NHS Mail, I found that the clinicians had more confidence and trust in the technology, which was when I was listening to Adrian talking, and that's the big thing. Do they trust you to do it? Can they rely on it? And I think that's one of the big wins, I think. And I think that's something that we hopefully will be building on going forward.
Can I come in there,
Yes, please
Richard?
do.
Yeah, I absolutely agree with Justin in terms of that trust in technology, and the ability then to deliver together is really important. Because I think, you know, we've worked in separate silos for a long time, and it doesn't. So in the Frimley Health and Care System, we've got a Frimley Academy, a leadership development program. But as part of that leadership development program, we have a separate program which is called Wavelength. And it's for actually people who are interested in digital technology. They may not be the experts in digital technology, and it's for clinicians and whatever setting that you're in, whether you're in a hospital setting or a GP setting or a community trust setting, we put people together to learn how to deliver transformation together. And what we've found in this pandemic is that it's been amazing how people have got together to solve problems in, you know, virtually really quick ways, and almost like a hackathon type of approach, but really involving clinicians in that conversation. Whereas I think in the past we have, you know, we've really separated the technologists within hospitals, within, you know, community services, or within general practice, from actually the clinicians themselves. And having that conversation together really moves the technology forward in a way that innovation can really take hold.
Yeah, I agree.
Yeah, so there's two big takeaways from that, isn't there? One is help clinicians shape the IT development from the beginning rather than partway through, and really sort of integrate their needs with the technology. And second, really grab and run with the growing clinical confidence around digital technology and help build that literacy and confidence so that we can, you know, expand the range of possibilities in the months and years to come.
Yeah.
Jonathan, what are you seeing among the trust and the health systems that you work with? What are you seeing about need for transformation? How are you helping them address it?
Yeah, I think there's a number of points there I probably want to cover. There's some really interesting conversations here that you know, fit nicely into my NHS background. I was head of IT at a large acute hospital, and something you said then, Adrian, about working with the clinicians was you know, key to my success really. When I joined, I spent time in the actual hospital understanding what the clinician needed, what the nurse needed, what the healthcare worker needed, at real grassroots cold-face level, because without understanding that, you can't deliver the right system for them. Too often IT picks a service they think's right because they think it's correct, and then just force it on the clinicians, and that's just not the way to do it. So yeah, what I saw again, what I think COVID has done is accelerated some big IT projects and IT transformations from potentially years into weeks or months. I worked on with a number of really large trusts at the very beginning within those first 2 weeks, enabling a remote access service to their patient care record, to their care systems that they didn't have before, because they've never had to work like this. They've been used to going into the hub and spoke model of going into an office, connecting back to the mothership, opening their patient care record, and simple. Suddenly, the edge of the network where everything is not controlled anymore. It's everywhere. It's your home. It's your endpoint. It's your phone. It's everything. And a lot of them were not prepared for that. And I think something Citrix had was this cloud service. Justin talks about cloud and be able to rapidly accelerate. It's a VPN-less system. It's an easy solution. It's just logging into a web page and accessing your care record. Certainly a number of the GPs we helped, they couldn't get their smart cards to work. They were trying to access their PCs in the office, getting their smart cards to work, getting to their local data. They couldn't do it. I worked with a very large trust on the South Coast, and we enabled 2,000 GPs to access their PCs within 2 weeks. We proved the solution within 2 hours. And that you couldn't do that without the cloud and without where technology is today and where the Citrix technology is today. So that was a really great experience for me, being able to actually help. What I'm seeing now, about where are we, 10 months on, 9 months on, a lot of interest now from large NHS organizations, CCGs, TSUs, acutes, saying, okay, we've put in these solutions, these quick wins, these ways of gaining access. I remember I spoke to a really large CSU last week who have 5 different ways for their GPs to access their PCs in the office. Some of them are having to go and leave their smart cards in the office, in the keyboard, just to allow that to work. They're now coming to us at Citrix saying, well, if we do this properly, strategically, what is the solution? What does it look like? And now being able to put my architect hat back on from when I worked in the NHS, properly solutionize with them and put in the correct solution now, I think is a really exciting time. I'm really looking forward to working on some great projects over the coming months.
That's that thing that you said about scale and resilience, Jonathan. In terms of that, yeah. I think absolutely it's actually kind of looking to the future around how we can develop that, because actually you know, we want to come out of this pandemic in a much better state. And I think, you know, we have done, there's been a lot of quick fixes going on, but actually to make it, to keep it and to keep it resilient and to keep it as a trusted technology is really important, because actually as clinicians, you know, if we're not very patient if things don't go right, and you know, whether that's a printer that goes wrong or whether it's, you know, the technology that doesn't connect when you're in a patient's home, so I think actually having that strategic view, building and underpinning kind of the work that's gone on is going to be a major theme going forward, and I absolutely agree with kind of that comment.
So we need to go and backfill some of the pretty on the hoof innovations that have taken place.
It's been fantastic what they've done. You know, the reactionary piece, the IT teams I've spoke to were working through the night for days on end to get all this stuff connected and working. Absolutely fantastic. But now we just need to take stock of where they are, where are the shortfalls, what if we do this strategically now rather than just a tactical fix. And I think that's the exciting bit, where the Citrix cloud service, what Justin already had in place, what my old hospital, Portsmouth, used to have in place, that solution that enabled them just to literally pick up and just work from home without any worry, without any change in the way they already worked, was fantastic.
Jonathan, had a question come through for you on the Glisser Q&A. So did you sort of gather information about the workflow when you're sort of working with a trust? Did you gather workflow information about, you know, who needs to connect up with what the system?
Yeah, I think the patient care pathway was really key. And when you spend time with the clinician, whether that's doing his ward round or whether you spend time from the emergency department experience of someone coming in and presenting to then them becoming an outlier within the hospital or moving to a certain ward or specialty, understanding that flow and then how the IT needs to follow the clinician throughout that, whether that's the care record from a digital perspective or actually the desktop they're working on, which is why from a Citrix perspective, we'll always say a virtual desktop. You know, you shouldn't be tied to a physical endpoint that you have to carry around with you, or a physical endpoint that might not have the right application on there or the right version of Java, or, you know, your smart card reader doesn't work. It should be a virtual desktop that just follows you as you work with your patient. That is absolutely key in terms of transformation. And I think too often IT departments, it's no fault of their own, are either underinvested or that the desktop, the basics doesn't get done properly. We're too busy looking at the integrated care record and actually joining up the clinical systems. Brilliant, it needs to be done. But we also need to get the bedrock, the foundations right as well.
Justin, you've already touched on this a little, but so how did you sort of get to understand the workflows and the needs around your clinical teams and translate that into technology?
Yeah, I mean, it's quite interesting in the conversation. I mean, it literally is, you need to get, you know, John's mentioned it, you need to get close to a cold face as possible. And I think when they designed my role, I came back from the private sector work back into the NHS, is they designed it with a bit of spare capacity so I could spend that time. You know, a lot of people, you know, just to go and spend a day or a couple of days. So when we did the community, it was a lot of kind of, modeling, workflows and stuff like that, but a lot of observations and revisiting, because you know, I think I mentioned this yesterday on another call, is, you know, I think there's only like three HIM7 hospitals in the UK. So there's still a lot of stuff that goes on outside the EPR. And the closer you get to the community, which is really interesting, the closer you get to kind of the inter-agency working. I mean, in this part of London, where we're in the shadow of Guy's and King's, a lot of our community service teams, you know, with the contract transfer from primary care networks, the PCN networks, they actually work for multiple organisations. So there's a lot of kind of talks across local authority, and there's just a lot of stuff still going on outside the EPR, which is the technologies you need to deal with. So yeah, just a combination of just good judgment, good relationships, and just kind of, but I think it's about getting some movement, and clinical engagement. Kind of an interesting point is, you know, we have people like Adrian, and we will have chief clinical nurses and things like that. but you need to actually go through the layers, you know, which we did a lot in the community. So we talked with a lot of the applied healthcare professionals, a lot of the physios, you know, people come into healthcare because they, you know, they want to work with people, you know, and there's some of them interested in technology, so they will have a bit of time, but they won't have, like, you know, 5 days a week for you. So it's just work the layers and just build those relationships. I think is really important.
I had a fascinating conversation with a physio lead at Guy's actually about how they started doing virtual physio sessions and really thinking from core principles how you did that over a camera is very impressive actually.
Yeah, and some of them they just come back and say, you know, how do you do this with cloud service? Okay, go the options, give them kind of access to the tool set and say, I can help you, but I can't necessarily do it for you. And, you know, just those relationships work, especially the younger ones, really kind of, you know, and it could be just a small thing. It could just be a small electronic form that makes an impact to the service somewhere.
Yeah. Adrian, sorry, did you want to come in, Adrian?
Well, no, I was just going to widen the conversation out to not necessarily just health professionals. And I think, you know, I think what we've learned in this pandemic is actually that, you know, we need to be able to deliver care. And part of the long-term plan and the Aging Well program that I support the clinical leadership on is around how we deliver care through the communities, and that some of that care actually could be delivered or is delivered by local authorities or providers of care, and you know, the care home sector is an example as well, where you know, it's not the NHS which is delivering that care. It's providers and within a social care setting, and really there is also a need for these technology solutions to be able to deliver there, because one part of our program is called the urgent community response, and actually getting care into a person's home within 2 hours or rehabilitation within 2 days of a person leaving hospital needs those solutions to be in that person's home, but they're not always NHS solutions. They're very much kind of part of what that community asset is, what the community has to be able to support that person in their own home. And it goes back to that point around personalisation of care, which is so important with this, because it's not always an NHS health professional who can give the best care in a particular situation.
Yeah, I just follow on from that in terms of one of the large ICSs that I'm working with right now. You know, they've surveyed this experience. They've got feedback from the staff that are working at that coalface, whether it's not actually a clinical medical professional, it's actually the care home, for instance. Yeah. They're looking at this approach of actually, let's get the identity of that person correct and the clinical system, and then how they access it. And that access needs to be from any device, anywhere, anyone's home, but it needs to remain secure. There needs to be a secure way of identifying that person that's accessing that record. So unless there's a joined up approach, that ICS joined up approach, and it looks first at these basics before we start looking at the clinical system, they've got to get that bit right. And that's
just
really
had a comment come through here. It says, I'm currently sat in the room where we are delivering cardiac rehabilitation sessions. We've come so far to be able to support our patients digitally so they can continue their rehab through and beyond COVID. And that rather neatly sums up, I think, the creativity that clinicians have shown. You must have come across this a lot, Adrian.
Yeah, no, absolutely. And I think one of the things that we're learning through this pandemic is, and I think this is going to be a great need going forward, is the deconditioning that happens throughout this pandemic. You know, we're all in this second lockdown now. And as we get older, the importance of exercise, the importance of the fundamentals, but we need to be able to have systems to support people to deliver some of that, or to support them in looking after their own care. And actually, you know, there's specialized services like cardiac rehab, but I think even more generic services to be able to deliver exercise programs to older people in their own homes to support them in there. And there's no reason why some of these programs can't be delivered with the secure platforms to be able to personalize that, to get health information, which is important in the context of that person's rehabilitation. It is important, so that the professionals are leading that approach with the knowledge of secure information, but using kind of exercise and other interventions as a way of pulling people out of this pandemic into a better place, to be able to get to the recovery, if you like, and rehabilitation back into normality. So I think
one thing I've come across is with the relationship between GPs and care homes is that the use of remote monitoring during the pandemic has increased the confidence of care home staff in knowing what normal is for each of their residents, and knowing what is and isn't an emergency. I've certainly come across one example where the number of unnecessary blue lights plummeted, and the number of appropriate blue lights, they've got it right.
Yeah, there's a big program, and I think for this is an area which I'm leading in terms of oximetry, COVID oximetry at home is a program within the NHS, and that program is delivering across the country to people who are who have got COVID symptoms, but who might be at risk of deteriorating in the community. Now, part of that COVID oximetry at home program is a section on people in care settings, residential care settings, nursing care settings, but also in the community, maybe in sheltered accommodation. What we've seen is that technology has enabled systems of care to be able to support those frontline workers, the carers in the care home. And it might not necessarily be a nurse; it could be a carer who's an unqualified member of staff, to use very simple devices like pulse oximeters to be able to spot the deteriorating signs of a resident before they actually deteriorate. This thing called silent hypoxia. And for me, that is a legacy, because we know that older people in care settings will deteriorate, and spotting those signs early, whether it's COVID or non-COVID, and sepsis is the other example, is a really important factor. And so the more that we can have the technology to be able to support individuals, help them use that technology properly, but also transfer information to professionals outside of the care home setting so that they can understand that information and understand it in a way that we produce a virtual ward type of environment for them to be able to work in. And that technology is accelerating at pace. And, they're up and down the country throughout this pandemic and through COVID, in the last few weeks, we've seen that really take off. And then the other bit is actually the virtual ward work, which has taken, so people are being discharged from hospital, having been treated for COVID with oxygen, but transferred at an earlier stage than they would have normally back into their own homes to recover. But having that virtual ward delivering support to them to be able to, and through teams, through clinical teams, which are usually hospital teams, is a feature which is really in the last 3 or 4 weeks being introduced nationally. So very much that technology connecting up, but putting professionals and residents and patients and their carers into that solution.
Just briefly on that, Adrian, the questions come through. Is there a digital divide, particularly for older people with these programs? I know with some of these devices, they've been distributed free, haven't they, like the oximeter and so on?
That's right, and I think older people use technology, and I think we have to be careful around that digital divide, and we do have to be careful. But I think actually kind of a lot of it is supporting the carers also to deliver some of that care, and it's also about individualizing that and personalizing it and using other ways. So so sometimes some technology solutions may not be suitable, and actually, if we're talking about technology, it could be a telephone call and a piece of paper is sometimes suitable for some individuals, whereas an app might be suitable for others. So I think we have to kind of use technology in its broader sense, and actually for older people, sometimes a telephone call and a piece of paper on a COVID oximetry at home diary, for example, might be the right method, but it's a personal kind of choice, I think.
Another question for you, actually, Adrian, come through, and a subject I suspect might be close to you and your colleagues' hearts. Says feedback suggests that sending clinical correspondence such as discharge summaries, clinic letters electronically and securely is not yet mainstream from secondary care to general practice. Is that your observation, and what could be done to encourage greater sharing of information between secondary and primary? Is it just culture, or is it the technology?
I think the two go hand in hand a lot of the time, Richard. I think for me, I think the technology actually flows. So actually, you know, in general practice, we're now much better at receiving information from hospitals, but we receive information from a wide variety of sources. It could be an email from a relative to a piece of professional information from a discharge from a hospital, and the issues that we have in general practice is understanding that information and acting on that information. Right. Now, as a GP, when I first came to the practice, we would have that information in letter form, and I'd have a basket with the letters which would come into me every morning. So that would be the way that it was processed initially. That became unsustainable because actually one basket became 2, became 3, became 4, and actually you could spend all day reading information and trying to digest it. Now we have a workflow team in the practice. Everything comes in on the document management service, is looked at by an admin team who've been trained to look out for the bits of information that need action, and then those actions are transmitted electronically to the actual relevant clinician. So it might be to a pharmacist in the practice rather than a GP. So actually we're making much better use of a multidisciplinary team approach. I think the culture change goes with how we not use that two-way, not that one-way communication, but actually have much more of a two-way conversation. And I think things like advice and guidance and developing systems where clinicians can communicate together without necessarily doing that in a chunky paper-based format actually becomes much more of a real life and actually kind of supporting individual care in a much better way.
Jonathan, we hear a lot in the NHS about legacy systems, and they sound like a sort of block in the road in terms of transformation. Is that true? Do we have to rip these systems out, or
a block in the road? That's a difficult one. I think at my hospital, when we assessed our clinical systems that were in use, it was over the 400 plus mark. Many of which were written by one man and his dog that's no longer supporting that piece of software. But you can't just take it away from that department or that specialty because it's serving a very key service to them. And the other thing often is in place is lots of access databases that have been developed by clinicians that are no longer there, but actually have become a mainstay of that department. It's getting rid of them. Yes, there has to be a transition from them to that EPR approach, whether that's one of the big ones like Epic and Cerner and Allscripts, or whether that's a homegrown best of breed approach where you build a portal to sort of manage and give you a single view of all of these disparate systems. I think one thing Citrix helps with in that is we bridge that gap. We allow you to still access those old clinical systems that maybe require a very old version of IE or a really old version of Windows OS that really isn't secure. And that new EPR, we can sort of bridge that gap and deliver it in a single view or to a single device. It really is a great way of helping you transition from old to the new. One thing as well, like Adrian, there's a number of points you made there about the clinical systems and the use of them and whether we still use pens and paper or we use a modern app. I think it comes down to time for me. Time is absolutely critical in hospitals and in healthcare. If we're taking away a clinician's time, a nurse's time from caring for their patient, from understanding their care pathway and what their treatment is, because IT is in the way or is a blocker or is a slower pair. I know apps that were put in our hospital and you time someone writing on a piece of paper and filling out a form on an app, the paper and pen wins. We need to make sure these systems we're putting in are saving time. If IT is in the way, if logging into a PC, if finding that computer that's free because it's not in use or it's got the right app on it or it's got the right medical record is wasting time, we need to get rid of that. That's really, really key. And often some of these systems, certainly with my project at Portsmouth, the key of our project was saving patient time, returning time to care. If the problem was that the finance guys don't see that as that's not a financial benefit to the hospital. I'm not going to get my £1 million investment for that. They want to know, is it going to save me money buying PCs and replacing Windows 7? And that's a real shame because I think actually saving time and providing better patient care should be the key to all of these projects.
Yeah, absolutely, Jonathan. And in fact, in general practice, there were 10 high impact changes for general practice, which took place. It was a program which started probably about 4 or 5 years ago, and the whole element of that was around reducing time to care, and that's really where the document management and working with workflows, actually what the whole the pilot showed, it can take away, doing that clinic letter sorting out kind of and all the other letter sorting out issues can save up to an hour's clinician time a day in general practice, and an hour of not having to do those things, and actually getting more front-facing patient care is, it means a really much more efficient system where patients get their needs served in a more responsive way than was happening before. So yeah, absolutely agree with that kind of thing.
Yeah, I mean, there are some quite astonishing estimates around about the time you can save with effective handovers between shifts on a ward, for example.
Yes.
Depending on the use of information. Justin, what's your experience of that? So in terms of trying to make the systems ideally user-friendly, so they just seem seamless and quick and help your working day rather than add to your stress?
Yeah, I mean, it's a challenge because I think Jonathan highlighted it, is we're not starting from a greenfield site. There's a lot of legacy there. Healthcare isn't that much different to other industries. I think maybe finance may have the same challenges. There's a lot of stuff that we need to deal with. There's a lot of applications out there. Yeah, a CIO's nightmare, but they're not all that important. So I think as a IT force, IT industry, we just need to kind of prioritize on what's really important in terms of those applications and have realistic stuff. But yeah, you always kind of, and there's only so much focus, there's only so much things we can do at a time. So it's kind of always having to juggle that. And for me, it's all about making nudges forward. I mean, we've kind of had a luxury in the sense that a lot of things have rapidly changed over the past 12 months. But it's just all about developing that digital maturity over a year, over 2 years. It's and just continue where we are.
But do you feel that the whole perception of the hospital about the need for technology has changed?
Yeah, I mean, I think it's naive to think that the clinicians or people don't really understand about technology. It's about whether enabling them to grasp it. I think before, I think I pointed out before, pre-COVID, a lot of clinicians would probably think, oh, that's for somebody else in the US or somebody else there. It's kind of more tangible now. And then I think that, like I say, is they trust it, they have confidence in it. So I hope, and I'm beginning to see that they're more willing to invest time in it, I think. Yeah.
Adrian, we're on the cusp of integrated care systems. Of course, you're ahead of the game where you are in terms of those systems. You referred earlier to partners such as local authorities. What do you think we should take from the pandemic when we look at those integrated care systems and how we share information across those systems?
It's a really relevant point. I think kind of a lot of the time that sharing of information needs to be underpinned by an element of trust and culture within your system. And that takes sometimes months and years to kind of enable that. And I think where we know integrated care systems have really driven that is where they're built on the structures around relationships and trust between local authorities, between healthcare providers, between new healthcare providers or primary care networks, for example. That trust has then been centered on an ambition for better health outcomes for residents in a local population and improving those health outcomes, which is, just part of what primary care is about, really. And primary care is in the definition of kind of, improving outcomes based on the resources that are allocated to you. So in our system, it's the Frimley pound. We've got £1 to spend. How are we going to spend that, spend that money to the best advantage? And it's not always a health solution. It's going to be often a care solution. And what I'd say is that kind of those trust and relationships are underpinned by good information sharing agreements and governance around that, so that people feel secure with the information that they've got. And once you build that, then you've got the intelligence and you've got the ability then to really think about your population health and well-being and the outcomes in a different way than you have thought before. Because actually, you know, what we think as NHS professionals people want is not necessarily what they want and their ambitions. And so one of the parts of the programs nationally that I lead is around anticipatory care, thinking about what's important to people and individuals when they've got complexity in their conditions and everything else. And it's about that setting and being able to make sure that the care that they get is the right care at the right time, but also it's not just about healthcare. It's actually about kind of what their ambitions are, to be connected to society, to keep connected to society, to be able to exercise, to be able to socialize, and that's difficult in this pandemic, but you know, in the future, to be able to keep the connections with society, which is less important sometimes than an ambition to do to have a surgical procedure or something else. So I think in answer to that question, a knowledge of your community, the resources that you've got, underpinning trust between organisations, and the development of a shared governance around information sharing and data, and then be able to use that for population health intelligence.
Right. Now, thank you. So I'm now going to ask our three panelists to sum up. And so I'm going to ask them to respond to two things. One is a question that's popped up from a clinician saying, how can we drive this forward as clinicians? Because our hands are tied by financial red tape. And although money has been arriving at NHS in large bundles, there are still financial constraints. So how do clinicians work with that in the future? And really just give your 2 or 3 takeaways from today's discussion and your experiences over the past year about how we get connected health in the months and years to come from what we've learned. Jonathan, would you like to begin?
Yeah, from a clinician perspective, I get that it's a difficult one. I think there's always a disjoint between what the clinicians wanting and IT and the technology teams, and they sometimes don't even know who to contact or who to speak to. There's often certainly from my experience, someone who helps build those business cases to perhaps go out and buy a new clinical system or replace some technology. It's building that business case, but also finding a business case champion within the IT department and working together with them. We used to have a team of staff, that Portsmouth still do, that go out and embed themselves with the different specialties within the acute trust and within the community, and help build those business cases together. So you need to find a champion within IT that can help build your business case that then gets put to the trust board for funding. And it's really spelling out exactly what you need. They've been really strong in how you want to work. You know, we want to work like we sit at home and watch Netflix. It should just be easy. Yeah. We've got to spell that out from the clinician to the IT team and remove that disjoint, remove that old view.
That's a really good answer. And just perhaps one thought, if you quickly share with us, Jonathan, about what you're taking away from the past year.
I think it's been a really difficult time, and it's put a huge strain on the NHS, and it's been amazing to see how they've responded. I think it's now time to try and look at the amazing transformation that's happened over a very, very short space of time, and say, well, why can't we do that again? But this time, let's do it strategically. Let's design the system to meet all of the needs, because often some of these needs are still coming out even now. Because we're still, on this path of COVID, and I think we need to take all of those needs, all of those problems, the issues that we faced, and challenges that we rose to and dealt with, and put them into a strategic direction. And we need to be asking for funding from the centre. And put my NHS hat back on. Look, I'm saying me again. It's very difficult once you work for the NHS; it never quite leaves you. So yeah, I just think now's the time for change, but strategic change, not these tactical solutions we've had to do.
Brilliant. Justin, very briefly, what's your takeaway from the year?
I think takeaway, it's just rapid change, and then I think we're entering a period of just reflection. Like I said, there is money available. There's only so many resources and focus, so it's just take stock. I mean, the NHS is pretty much like our personal lives. We're just trying to work out what the new normal is going to be. So a period of reflection towards the end of the year is my stuff.
Great.
Picking up on Jonathan's point quickly is, yeah, building, get involved if you're a clinician. It's not just about IT and clinicians, it's about those finance partners as well. It's about everybody else who needs to get involved, because there's not a shortage of ideas, but there's only so many things we can look at once.
Yeah. Okay. And finally, Adrian.
Yeah, so I was a CCG chair in between 2013 and 18, and we were one of the most challenged financially CCGs in the country, on the bottom 10% on the bottom 10% of funding, and we had an acute hospital which was in real financial difficulty. So I've been there in that difficult place. And how we, over a period of 5 years, transformed ourselves from being a CCG requiring improvement to being an outstanding CCG was through 4 things, really. The first I'm going to say as a clinician is curiosity, kind of thinking about, things and actually going in and working. And clinicians are great at curiosity, but also, there are lots of other people who are interested in curiosity. Thinking about collaboration, we couldn't have done it as a CCG on our own. We had to reach out to several CCGs and the Department of Health and, and others. And so collaborate and work with your communities. Use champions, and Jonathan, said that around kind of champion. You've got some great people who have got untapped resources within them to lead. Use those people, and then develop those and use those connections that you've got in your system, because your population, the resources in your local area, and I think all of those things are relevant in terms of where you are. You can always, despite being in a financial situation, find that there are so many resources which are duplicated, and actually we are throwing away resources all of the time. By simplifying, making things easier, connecting, you can actually make such a big difference. So don't let that stop you. Let it encourage you.
Brilliant. Well, thank you so much to our 3 panelists, Justin, Jonathan, and Adrian. Thank you to Citrix for their support for this event. I hope you found it a stimulating and rewarding discussion. And the best of luck. Thanks a lot. We look forward to seeing you again soon. Bye-bye.
Thank you.